Introduction. Brain tumors pose a significant health risk for dogs and cats, leading to neurological disorders and mortality. The incidence rate is notably higher in these animals, with up to 4.5% in dogs and 2.2% in cats, compared to humans, where the rate is up to 25.48 per 100,000 people. Historically, these tumors were often confirmed only after death, but advancements in imaging techniques such as computed tomography or CT scans and magnetic resonance imaging or MRI have enabled more accurate detection. Despite these advances, diagnosing brain diseases remains challenging because various conditions can appear similar on imaging. For instance, a study by Wolf and colleagues found that 23 out of 57 cases of meningioma were misdiagnosed based solely on MRI, without other clinical data, being mistaken for other brain tumors, normal findings, or bacterial infections. When a definitive diagnosis is lacking, palliative care can lead to a poor prognosis, with a median survival of only 2.3 months as neurological symptoms worsen. Therefore, a definitive diagnosis based on histopathological examination, that is, examination of the tissue under a microscope, is essential before treatment in order to determine the best approach. This approach might include surgery, radiation, or chemotherapy, and a histopathological diagnosis also helps assess prognosis based on the characteristics of the tumor. Obtaining a sample for this examination is typically done through a brain biopsy. Brain biopsies are common in human medicine but less frequent in veterinary medicine due to factors such as the smaller brain sizes of animals, limited expertise among veterinary professionals, and economic and ethical considerations. In veterinary medicine, most brain biopsies are done using an open technique that involves surgical resection, which is best suited for tumors located on the surface that are easily accessed. When surgery is not an option, a minimally invasive closed technique using stereotactic guidance, which is a technique using a three-dimensional coordinate system, is usually used. The frame-based method, where a rigid frame is attached to the patient's head, is considered the gold standard in human medicine, but can cause patient discomfort and reduce flexibility. Recent advancements have introduced alternative methods, including three-dimensional printed brain biopsy guides or 3D BBGs and neuronavigation, which have their own advantages and disadvantages. Three-dimensional guided biopsies are cost-effective and easy to use, but they do not allow for trajectory adjustments during the procedure. Neuronavigation allows for adjustments to the trajectory of the biopsy needle, but is more expensive and requires additional preparation. Despite these differences, accuracy is paramount for both diagnosis and patient safety. While previous studies have looked at the accuracy of these techniques by inserting biopsy needles into cadavers, there is limited information on direct comparisons of accuracy based on identical criteria. Therefore, this study aimed to directly compare the accuracy of 3D BBGs and electromagnetic or EM neuronavigation in brain biopsies using a skull-brain tumor model or SBTM created with three-dimensional printing technology. The researchers hypothesized that there would be no significant difference in accuracy between the two methods and also evaluated the effect of biopsy needle length and skull shape on accuracy. Study design. The study used computed topography or CT data from 12 dogs and 3 cats without brain disease, obtained at Gyeongsang National University Animal Medical Center between May 2023 and March 2024 to create a total of 30 SBTMs using three-dimensional printing technology. 2 models were created for each data set. The CT data was processed using computer image processing and modeling software, called 3D Slicer, to segment the skull, create enclosed spaces and smooth the surfaces. The three-dimensional skull models were then exported for further processing. Length and design measurements were taken using computer-aided design or CD software. The skull shape was quantified using skull length, skull width, cranial length, and cranial width. These measurements were used to calculate the skull index and the cranial index. An 18 mm diameter opening was created on the left side of the skull, which was covered with a three-dimensional cap with a 6 mm hole for the injection of agarose gel. A 10 mm cube marker was added to the back of the skull to ensure accurate alignment of pre- and post-biopsy models. All the models were printed using a three-dimensional printer and resin material. A brain tumor model mold with a 6 mm radius spherical cavity and a 4 mm diameter sprue was also designed using CAD software and three-dimensionally printed. These molds were filled with a mixture of agarose gel, Evans blue and barium to create the brain tumor models. The blue dye was added to visually confirm if the biopsy was successful. The brain tumor models were inserted into the skull models through the opening at the right piriform lobe, which is the front part of the brain near the olfactory bulbs. The opening was sealed with a cap and clay, and 1.5% agarose gel was added through the cap hole to complete the SBTM. Figure 1 in the article visually represents the process of the SBTM creation. It shows different components like the skull model with the opening and cap, the brain tumor model mold, the placement of the tumor model within the skull, and a transverse CT image of the completed SBTM. For the production of the three-dimensional printed brain biopsy guides or 3D BBGs, the SBTM was scanned using a CT scanner. The CT data was used to create three-dimensional reconstructions of the skull and tumor models using CAD software. The skull and brain tumor models were aligned in the software so that the tumor center was at coordinates x equals 0, y equals 0, and z equals 0. A 1 mm radius sphere was set as the target point at the tumor center. Then, a cylinder representing the path of the biopsy needle was created from the target point to the right side of the skull, where the 3D BBG would be attached. The length of the cylinder was measured as the skull to target distance. A 5 mm thick rectangular footprint was created around the cylinder. The cylinder was extended by 30 mm and 2 more cylinders were added to the end of the trajectory. The farthest cylinder was hollowed out, and the closest cylinder was removed to make space to view the biopsy site. Supports were added to connect and reinforce the trajectory guide. The 3D BBG was developed based on a previous study by Shin and colleagues, and printed using a similar method. The design process for the 3D BBG initially took about 5 hours, but it was eventually reduced to about 1 hour as the design became more standardized and the researchers became more comfortable with the software. The total length of the biopsy needle was calculated as the sum of the skull to target distance, plus 30 mm. Figure 2 in the article shows the 3D BBG design, the 3D BBG attached to the SBTM, a brain biopsy using the 3D BBG, and a sample of the brain tumor model obtained from the biopsy needle. 30 brain biopsies were performed for the study, 15 using 3D BBGs and 15 using EM neuronavigation. For the biopsies using 3D BBGs, the 3D BBG was positioned on the right side of the skull model, ensuring the contact surfaces matched. A craniotomy, which is a surgical opening into the skull, was made using a cutting burr. The 3D BBG was secured using Kirschner wires, which are thin, metal wires. A stopper was placed on the biopsy needle to match the total length of the needle. The needle was inserted through the guide until it reached the stopper, and the sample was obtained from the tumor after creating negative pressure by aspirating 0.5 milliliters using a syringe. The presence of blue agarose gel on the sampling window of the biopsy needle was used to verify that a sample was obtained from the tumor. For the brain biopsies using EM neuronavigation, the system included a neuronavigation cart, a patient tracker, an emitter, and a tracer pointer. 5 fiducial markers, which are reference points, were attached to the SBTM. 1 marker each was placed on the right frontal bone, parietal bone, and zygomatic arch, and 2 on the left side of the skull. The patient tracker was attached to the hard pallet, and the model was secured to the operating table. The emitter was positioned to detect the area of the brain biopsy. The CT data were uploaded to the neuronavigation system, and the fiducial markers and SBTM surface were registered using the tracer pointer. The system's accuracy was maintained at 0.5 mm or less, and the registration time did not exceed 5 minutes. To visualize the biopsy needle tip, an EM stylet was mounted on the biopsy needle. The virtual trajectory on the planning screen was extended by 55 mm to align the needle tip with the planning point. The biopsy was then conducted using real-time neuronavigation, and a sample was collected. Figure 3 shows the registration process using a tracer pointer, the brain biopsy using EM neuronavigation, and the neuronavigation planning screen, including images in transverse, sagittal and dorsal planes, as well as a trajectory view. The accuracy of the brain biopsies was assessed by measuring the deviation of the biopsy needle placement from the intended target. This was done by comparing the pre-biopsy and post-biopsy models using CAD software. After the biopsy, the SBTM was reimaged using CT. For the biopsies using 3D BBGs, the pre- and post-biopsy models were aligned using the cube reference marker, and a sphere was placed at the end of the needle track to mark the needle tip point. For EM neuronavigation, the post-biopsy model was aligned with the transverse, sagittal and dorsal planes of the neuronavigation system, and a sphere was created at the intersection of the neuronavigation planning points. In both cases, the needle placement error, which is how much the needle tip deviated from the center of the tumor model, was calculated using a mathematical equation. Figure 4 shows a transverse CT image of a skull-brain tumor model after the brain biopsy, pre- and post-biopsy models overlaid in three-dimensional rendering, and the needle tip point and the biopsy target point after analysis. Statistical analysis was performed using SPSS software. The normality of the data was assessed using the Shapiro-Wilk test, and the Levine test was used to determine the equality of variances. The needle placement errors were analyzed using independent t-tests, and the relationship between needle placement error and other variables such as skull-to-target distance, total needle length, skull index, and cranial index was analyzed using multiple linear regression. Statistical significance was set at p less than 0.05. Results. The study successfully created 15 different SPTMs, with 2 models for each, based on the CT data from 12 dogs and 3 cats, including various breeds such as Pomeranians, Shih Tzus, and a Dalmatian, among others. The median body weight of the animals from which the skull models were taken was 5.6 kilograms with a range of 3 to 26.8 kilograms. The median skull index was 70.19, with a range from 49.96 to 93.89, and the median cranial index was 58.53, with a range from 45.06 to 79.58. 30 brain biopsies were performed with 15 biopsies in each the 3D BBG and EM neuronavigation groups. The median needle placement error for all the biopsies was 1.75 mm, ranging from 0.82 to 3.16 mm. The median error in the 3D BBG group was 1.79 mm, ranging from 0.94 to 2.94 mm, and for the EM neuronavigation group it was 1.68 mm with a range from 0.82 to 3.16 mm. There was no statistically significant difference in accuracy between the two methods. Table 1 in the article provides descriptive data on needle placement errors for the total 3D BBG and EM neuronavigation groups. The median values for the skull-to-target point length, total biopsy needle length, skull index, and cranial index, along with their correlation to needle placement error, are shown in Table 2. The median differences between the 3D BBG and EM neuronavigation groups were 1.82 mm for the skull-to-target point length and 56 mm for the total biopsy needle length, with the latter having a greater difference. No statistically significant relationship was found between the needle placement error and the 3D BBG group and any of the measured variables. However, in the EM neuronavigation group, a statistically significant relationship was found between the needle placement error and the total biopsy needle length. Blue agarose gel samples were collected in both the 3D BBG and EM neuronavigation groups, and post-biopsy CT confirmed all samples were from within the tumor model. Discussion. In this study, the researchers successfully performed brain biopsies on SPTMs using 3D BBGs and EM neuronavigation, demonstrating that both methods can be used for brain biopsies on patients with diverse breeds, sizes, and head shapes. The median needle placement errors of 1.79 mm for the 3D BBG and 1.68 mm for EM neuronavigation are consistent with the previously reported accuracy range of 0.83 to 3.6 mm for stereotactic brain biopsy studies. As hypothesized, there was no significant difference in accuracy between the two methods. The use of three-dimensional printing technology offered several advantages. The models avoided the challenges of sourcing cadavers, allowing the study of various breeds, sizes, and head shapes. Furthermore, using three-dimensional printed models was ethically acceptable and cost-effective, with the SPTMs costing only between $3 to $9. Unlike other studies, the models in this study were simplified to only include the skull, brain parenchyma, and tumor in order to save time and costs. Future studies should include additional structures such as vessels and ventricles. This study was the first to evaluate the accuracy of brain biopsies using EM neuronavigation in veterinary medicine. EM neuronavigation functions by detecting changes in the magnetic field, which allows the system to be used in various positions and directions, but it can be affected by metal objects. A clinical benefit of EM neuronavigation is the lack of need for rigid head attachments, which are required for optical neuronavigation. Therefore, EM neuronavigation can avoid the need for additional anesthesia and prevent artifacts during CT scans caused by head attachments. The absence of rigid head attachments can also allow for head movement, which reduces patient discomfort. The median registration error for the EM neuronavigation system was 0.4 mm, with registration completed in a few minutes. The application of three-dimensional printing for precision surgeries of the brain has gained increased attention in veterinary medicine. Benefits of this approach include surgical planning using three-dimensional software, printing three-dimensional models, simulated surgical practice, and the creation of three-dimensional printed guides and implants. A key advantage is the patient-specific customization. For example, the 3D BBG used in the study can be attached directly to the patient's skull without the need for additional imaging or markers, which enables the procedure to be done with a predetermined trajectory and depth. Although the inability to adjust the planned trajectory is a possible disadvantage of this method, alternative pathways can be added to the design. To use 3D BBG in actual patients, a larger exposure area may be required to ensure proper contact with the bone. In this study, the absence of soft tissue made it easier to determine the precise attachment site of the guide. More research is needed to ensure 3D BBG can be used in clinical applications on areas of the skull that lack distinct anatomical structures. The small difference in brain biopsy accuracy between the 3D BBG and EM neuronavigation can be explained by the fact that both methods utilize stereotactic procedures using CT data. Positional information from the CT scan was used in both methods. In 3D BBG, the information is used to create the device, while in the EM neuronavigation, the information is used to visualize positional changes. In addition, the use of artificially constructed SPTMs may have contributed to the minimal difference in accuracy between the two methods. A previous study comparing these techniques in cadavers showed a larger difference in the median needle placement error. This indicates that the accuracy difference between the two biopsy methods in this study was smaller than in previous research. This study showed that both methods can accurately position the biopsy needle at a stereotactically determined target point, with no significant difference between the two. More studies are needed to compare the accuracy of these methods under the same conditions. While previous studies have found no correlation between needle placement error and biopsy length, this study found a correlation between needle placement error and the total biopsy needle length in the EM neuronavigation group. It is predicted that the error increases as the distance to the target lengthens. In the 3D BBG group, there was no relationship between needle placement error and either the skull-to-target distance or the total biopsy needle length because the 3D BBG was attached directly to the patient's skull, resulting in a shorter distance from the target. In the EM neuronavigation group, the external guide is farther away, resulting in a longer distance. More research is needed to further investigate the relationship between accuracy of biopsy, tumor location, and the total length of the biopsy needle. The study had several limitations. First, the accuracy of the biopsies was assessed through manual superposition of images, which may have introduced human error, even when using reference markers and CAD software. Second, the study was not performed in vivo. The SPTM was made of agarose gel, which is stiffer than real brain tissue, and does not represent actual intracranial pressure, which may affect biopsy accuracy. Finally, the researchers did not restrict the sample selection criteria, which may have compromised the consistency of the results, and future studies should focus on patients with specific breeds and head shapes. The study concluded that there was no significant difference in accuracy between the two methods, and therefore, the method chosen to perform a brain biopsy can be based on veterinarian preference, hospital resources, and patient condition. From VetNeuroJar, keep those minds inspired, hearts light, and tails wagging.